Welcome to this explainer. Today, we're jumping right in to shine a very bright light on a hidden crisis that's quietly draining our healthcare system. I'm talking about physician burnout, and specifically the grueling reality of the after-hours documentation workload. If you've been paying any attention to healthcare tech lately, you've probably heard all the buzz about how shiny new software is going to swoop in and give doctors their lives back. But as we're about to see, the true story is way more complex and honestly, much more urgent. Which brings us to the core question we want to tackle today. Why do doctors consistently work past 5 p.m.? We've all heard the pitch, right? That ambient AI listening tools will just magically clear a physician's schedule. But if you talk to literally any clinician on the ground, you'll quickly realize that just buying a scribe isn't the whole answer. In fact, if we only focus on the clinical note itself, we're completely missing the forest for the trees. To put this into perspective, a national survey by Veridigm of 360 independent practice leaders found that a massive 65% of clinicians spend at least 1 hour a day on documentation completely outside of their scheduled appointments. And it gets worse, 26% of them are spending 2 or more hours. That is a massive amount of unbilled, off-the-clock time stolen from their personal lives and families. So while independent practices are betting heavily on tech to fix this, they're kind of aiming at the wrong target. Okay, let's dive into this. The actual culprit driving all this exhaustion has a name. In the medical world, it's known as pajama time. And it's not just some catchy phrase. It represents the external documentation time that doctors slog through on their couches at night. It's made up of highly fragmented, cognitive switching tasks. It's basically exhausting manual data routing that completely drains a physician's energy when they really should be resting. So here's our roadmap for today. We're going to cover the pajama time epidemic, why AI scribes fall short, the missing administrative hour, our configure, buy, and build sequence, and finally, how to go about reclaiming time that matters. Starting with Part 1, the pajama time epidemic and the reality of the after-hours workload. You know, doctors didn't endure years of grueling residencies and take an oath to heal people just to spend their evenings manually routing data between disconnected computer systems. Yet, studies analyzing electronic health record event logs reveal a pretty harsh truth. For every single hour physicians provide direct clinical FaceTime to patients, nearly 2 additional hours are spent on EHR and desk work. 2 extra hours. A huge portion of this is just navigating disjointed systems designed strictly for billing compliance, not for actual clinical efficiency. These systems have essentially hijacked the doctor's day. Which leads us to Part 2, why AI scribes fall short and why the ambient scribe is absolutely not a silver bullet. Lately, the healthcare market has basically collapsed this incredibly complex operational burden into one simple directive: just buy a scribe. And don't get me wrong, ambient listening tech is absolutely a critical leap forward. An AI scribe brilliantly automates transcription and beautifully formats the clinical narrative. It hits the nail on the head there. But think about what it leaves entirely untouched. If a physician dictates a complex care plan, the AI doesn't magically queue up the lab orders. It doesn't draft that agonizing prior authorization request. It doesn't route the referral to the right specialist. It simply doesn't automate the clinical operations that result from that beautifully formatted note. Let's move into Part 3, the missing administrative hour, and where the rest of that time actually goes. Now, what's really interesting is how the workload breaks down. That AI scribe, it only fixes about 20 to 30 minutes of typing. That's just about 33% of the problem. But what about the rest? You've got inbox triage consuming nearly 25% of total EHR time, and then there's this massive 42% chunk taken up by prior authorizations, order entries, and payer paperwork. So if you just buy a scribe, you're leaving more than 2/3 of the pajama time problem completely unresolved. And the absolute worst offender in that remaining chunk? For sure, it's prior authorizations. The American Medical Association found that physicians knock out an average of 39 prior authorizations every single week. That eats up approximately 13 hours of physician and staff time weekly. 13 hours. You have highly trained medical experts spending 1/3 of their week fighting bureaucracy instead of treating patients. No wonder 94% of physicians report that this specific task contributes to burnout. It is literally the most acute administrative choke point in medicine today. So what does this all mean for us? It means different workflow components demand totally different automation strategies. An encounter note? Sure, that can be fixed with a point tool like an AI scribe. It's high impact, high automation potential. But inbox triage? That's about 25% of EHR time and requires deep EHR configuration. And prior authorization, burning those 13 hours a week? Because it requires pulling historical context across multiple systems, it absolutely demands custom workflow automation. You just can't fix the whole shebang with one piece of software. That brings us right into part 4, configure, buy, and build, the strict sequence for automation. So, the crucial point here is treating documentation not as a single task, but as a sequenced pipeline. If you just go out and buy disjointed software subscriptions, you're only going to create new integration headaches for your already exhausted doctors. To actually close this time leakage gap, practices have to follow a strict vendor-neutral sequence. We call it the rule of 3. Step 1, configure what you own. Step 2, buy narrowly. And step 3, build where unique. Let's break this down. Step 1, configure. Before you buy anything, you literally must exhaust the native capabilities of your existing EHR. A massive percentage of this documentation bloat is honestly just poorly configured systems. You've got to optimize internal templates, standardize your order sets, and tighten routing rules. So for example, prescription renewals bypass the doctor and go straight to the clinical pharmacist. Listen, if you don't fix those underlying routing rules first, adding AI will just process your bad workflows faster. Okay, once your EHR is totally dialed in, you move to step 2, buy narrowly. This is where you deploy commercial point tools for highly specific commoditized problems. And yes, this is exactly where the ambient AI scribe belongs. But here's the golden rule. These tools only earn their keep if they operate silently in the background. If a tool requires a doctor to open a new browser tab or manage a secondary login, it's failed. Every new interface is a context switch that just increases a doctor's cognitive load. Finally, step 3, build where unique. When a mid-sized practice hits the ceiling of off-the-shelf software, you have to build. We're talking about specialty-specific routing logic and complex multi-system handoffs. The best way to handle this is by using a smart-on FHR sidecar architecture. Basically, this is an application that sits alongside the EHR, keeping the EHR as the system of record without trying to replace it. Enterprise-grade engineering partners like Bay Tech Consulting specialize in this stuff. They build tailored sidecar apps that snap securely right into your existing frameworks. Wrapping things up with part 5, reclaiming time that matters. How we measure and execute the strategy. You know you could have the best tech strategy in the world, but if you don't establish baseline metrics before you start, you're really just guessing about your return on investment. Practice administrators absolutely must track 3 specific key performance indicators over a 30-day period before touching new tech. First, after-hours EHR time. This is your empirical measurement of pajama time using system audit logs. Second, chart closure leg, the time between the patient visit and the final signature. And third, inbox turnaround time. Without these baselines, you're flying blind on anecdotal evidence. And this brilliantly illustrates your action plan. For a mid-sized practice, here is your concrete 90-day pipeline to eliminate unbilled hours. Days 1 to 30, baseline measurement and configuration of your existing EHR routing rules. Days 31 to 60, targeted acquisition and piloting of your point tools, like the AI scribe, measured against those baselines. And days 61 to 90, workflow mapping and evaluating a custom sidecar build with an engineering partner to handle the friction points that are unique to your specific practice. Which leaves us with this final thought. The massive burden keeping doctors working past 5 p.m. is never going to be solved by a single software purchase. Buying a scribe is a fantastic start, but it still leaves 40 minutes of every administrative hour completely untouched. So I want to leave you with a question to ask your own organization. Is your practice treating documentation as a simple task to be outsourced, or as an operational pipeline that needs to be engineered? Think about it. Thanks for joining this explainer, and we'll catch you next time.